carrying them and being able to know the teacher is near the kids, or the kids are near the teacher, that sort of thing. And those could be used outside very easily. So there's no barrier to outside use.
Modern the witches' hats. They're quite often used outdoor in VH.
Oh.
Stick them on the witches' hats.
Okay. Okay, I'm new to that.
Traffic cone.
Oh, a traffic cone. Oh,
Sorry,
okay.
we call them witches' hats.
Yeah. Got it. No, that's great. In the U.S., that might cause it to be banned these days, but that's great. So you could stick them on there, and you could find something about proximity to them. But you could also have, children. You could basically capture how close the teacher is to different groups of children if you wanted to. So that has some attractive sides. I do also see here, though, a reference to screen time, and I don't know if that went by the wayside or if that was something which you were still considering, but it seems to me it's worthwhile, and I see to think about. How much are they using the phones? A child who is or is not responding, is that an explanatory variable that might help understand some of the outcomes?
Yeah. We're also wondering if you prompt them to use their phone more, do they then stay on it and keep using it, which is counterproductive to physical activity, which is what we're trying to encourage.
Good. And so screen time here, there's two sensors of relevance that Mohammed talked about, or two data streams of relevance, two data sources. One is how often the phone is on. Is the student plausibly using it? Another is actually which apps are being used and so on. And that is possible relevance, but it may be more sort of the screen time, how often it really is on. And I see here a number of steps per day, so that would be pedometry. And there is a pedometer screen in Ethica, but there's, as you said, wrist-mounted pedometers might be, attractive as a wearable, because it would be in a fixed location and can be just pinned down a little bit more. I think those are good components. I think one wants to avoid gilding the lily by having too many measurements. I mean, these are geographically specific activities, but for children, we know where they are during the school day, et cetera. So I don't know that we need GPS to tell us that they're in this playground or something. Certainly, one thing you'd want as a data source that we might not think of as that is surveys. And so we're going to be going into survey instruments, and those would be, I think, a big part of this.
And that's what that was our thing between the screen time and the inactivity levels. You're asking them a survey, and I've got my phone,
Right.
so I've got my phone.
Let me check my mail.
Yeah, I'll just check this.
Yeah.
It's like,
Yeah.
Would it not be interesting to maybe see how far they come to school, how far they go, how much walking they do going
Yeah, that's
home?
part of the active
riding
transport.
bikes.
Yeah,
So
active
you'd be able to
transport.
get a lot of that from just GPS plus
Mhm.
accelerometer, which
Fair
you
enough.
can differentiate car, bike, walking to some extent.
Vehicular versus non-vehicular, yes.
Yeah.
We've done quite a bit with that, although distinguishing like bus from car, which probably is not a germane here,
No.
that's harder. But yeah, I think, some significant insights could be gotten during that. I don't know that it strictly requires GPS, but it might give you a clue. So, okay, no, GPS signal would give speed, which is a key factor there for prediction, as well as.
It also tells you how far they're travelling to
GPS
school, so.
That's right.
So if someone who lives next door is not going to get much exercise, with
Yeah.
a kilometre they might walk.
That's true, but you're going to be also getting the accelerometry or the pedometry along with that would presumably co-vary with the distance.
I think we're actually trying to get them to, if they're within a certain distance radius of schools, to try and get them to walk.
Yeah.
Or even walk partway.
Yeah.
Yeah, well, just to tell you if they're actually doing it.
Yeah. So yeah, you could ask questions each day that might ask for that. For example, how did you get to school today? Would be a possible thing. which might then cross-check any inferences you make based on other data.
And why do you stop at McDonald's every night at night?
Yeah, that's what we were saying, a little survey should pop up saying, do you really wanna go into it, or rather than instruction.
So with dietary habits, we'll be talking about, I see it says lunch boxes, snacks versus meals, water intake. You know, there could be something there that links in more with the surveys, but again.
We would also think about taking a
Photo.
photo of the lunchbox.
Exactly. Show the contents of your lunchbox, yeah.
How often they refill their water bottle within the day,
Ah.
that's on the refill area,
Ah.
tap, that's where you put the beacon.
You could have a beacon at the water
Yeah.
spigot. That's interesting, so we know if they've gone to the well too many
What do you
times.
call it?
Yeah.
What's spigot?
What, water spigot? Well, it's a water fountain.
Bubbler.
It's getting big.
Yeah, it was whatever, yeah, because it's got every little station. I think they're all the schools including the SAT.
Yeah.
Good. Is there any evidence that children might, knowing they're part of a study like this, go to some trouble to fake their data?
Well, that's what, I think that's what you're saying about that first week, or generally there's that, there's that.
Need a washing period, so to speak.
That's right, yeah. Yeah, yeah, there may be a few pranksters in there, you know.
Yeah, but it would be fun after a while, so you give up the real.
Right, you know.
Well, find some way of rewarding them for doing the right thing and, yeah.
So maybe the photograph of every day, the lunchbox full of Twinkies or something, and floaters. I don't know. Boy, I'm trying to
That's
remember
ice
these.
cream and soft drink
What
for us.
are these unhealthy Australian things that you don't have corn dogs? You have.
Pluto pups.
What is it?
Dagwood dogs.
Dagwood dogs.
Depends where you come from, though.
Yeah,
Pluto
no,
pups,
Pluto
Dagwood
pups.
dogs.
Chico rolls.
Okay, yeah, we won't go there. Good. Any other comments on that, Mohammed? Do you wanna comment on this?
Nothing specific comes to my mind. I think the only thing I wanted to also mention, which I think was discussed, is we didn't talk much about surveys. We left it for the afternoon, but like basically the last session of today. But I think for a lot of these type of data, it's important to get some qualitative responses from individuals through surveys as well. Like
We're all getting a lot of this stuff already from surveys, so.
So what I want to emphasize is that these are not to substitute. The purpose of these data sources is not to substitute the survey responses. It's just to provide an objective measurements as well, which then the surveys can validate that.
Exactly.
Now, how we have to phrase it, especially with EMAs that are basically short surveys issued at any time, it can be a bit misleading because people might not want to answer it right away. Like something like picture of their food. We actually did one study on foodborne illness that we asked people to take picture of their food. It was a sample size of 100 people for 70 days. We got a very good response back. We got, I think, on average, 2.9 submissions per day we received. The population was university students, which are usually very compliant compared to, I don't know if it's the same, the same is valid with teenagers as well or not. But people very much like to take a picture of everything that they're eating and submit it. So that's
Many of them describe it too.
yeah, and many of them described it as well. Like, yes.
So how do you decide sample size for one of these?
The sample size is something that I think Nick you can answer.
Well, yeah, we'll be talking tomorrow about the recruitment and so on. There are, let's just put it this way, doing traditional power calculations to select sample size is not, it's not an easy thing for these. And I think that often what you want to do is you want to start with a small pre-survey to look at, or pre-study, smaller study, a pilot, not a technical pilot, but a pilot. You have to go through ethics and everything. It's a pilot study with a smaller group to get a sense of response rates and everything, get a sense of how complete the data will be. And on the basis of that, you can then try to understand, okay, how many people do you need in the study as a whole to get the requisite number of samples for the types of analysis you'll be conducting. So, an example of this is, we did actually recurrence events analysis looking at e-cigarette and cigarette use. And we did it with a small sample size, and that gave us, it was too small a sample size to achieve the statistical reliability we were searching for, but that allowed us to then plan for a much bigger study, which is part of a larger sort of tobacco grant from our Canadian Institutes of Health Research, which is going to be a much larger set of samples of people, and therefore we have some grounds for selecting the size. And reviewers love that, right? You have some data already, and you use it to decide the larger size. But there, you're going to be thinking about what some of your main analytic tools will be for analysis, and trying to select it based on that. There's other practical considerations involving costs, and some involving pricing, as Mohammed will.
Yeah, the cost also, because it's it definitely affects enrollment. The more you want to recruit, the more time you have to spend on that, and also the incentives. It directly impacts that. What I have to emphasize on, I have to mention one experience that we had. One of the teams we worked with, they did 2 studies. The first one, they paid them I think $40 per person for a 1-month study, and they went with a sample size of 80. And then they, just for the sake of experimenting, for the next one, they said we're gonna cut it by $20 and go with as many as we can, and they could get 180. So it just it worked. So it's the incentive is also, I think, something that we will talk about it tomorrow. It's it linearly affects the cost of your study, and it's very important to just get them enough, pay them enough to keep them motivated, but you don't want to pay them too much. So.
Yeah, and we.
Yeah.
Yeah, you can't pay. Yeah. Yeah. So we're dealing with the same thing with that Alberta Health Services thing, and one thing that may be quite useful. We'll talk about that tomorrow some. But one thing that we have done is some very innovative partnerships with organizations to give in kind.
So even there's studies that are done.
Community groups and so on. So the
early
YMCA
phase
giving
studies, the really early phase experimental ones.
But Michael.
There's remuneration, but not
Stupid
for.
comment on FPL.
That's going to be an interesting discussion tomorrow.
Yeah.
Counterintuitive to all business, I don't know, the scientific basis of business is poor anyway, I guess. But it's always supposed to be a linear relationship between demand and price, isn't it? No.
Not necessarily.
Is that not true?
Well, I would say that short answer is not really linear. But yeah, a lot of the time they treat it as linear, that price go up, then demand go down, or the other way around. But yeah, I don't think it's not necessarily always a linear.
So this
assumption.
phenomenon is not it's well described.
No,
it sounds
I
like
don't
it's
think so.
great.
Because a lot of the time there are actually a lot of strong evidence that if you give people incentive to do certain things, people actually don't do it. It's completely irrational and counterintuitive, but there are a lot of trial actually give you a couple of dollars to do certain thing, and you see that the behavior actually drop. But if you motivate them by saying you contribute to certain thing, this is what you help, massive increase in participation and compliance. So it's not always a one-on-one or kind of positive relationship between participant and price and things. Yeah.
In general, at the university, you're not allowed to incentivize anyway. Like
Yeah.
you can compensate people for
Yeah.
their time, but you're not allowed to
Right.
incentivize. So
Yeah.
So how
I
those
think
two are
that's
different?
no.
Compensating them for their time versus incentivizing them.
I think.
Because, for example.
Pay for their parking, maybe?
No, is it about time versus their
We're not even allowed to
commute?
do that.
it
We're-
depends on the group, and it can be quite different depending on who the participants are. But for example, if you want to get doctors, for example, say specialist
Yeah.
doctors to participate in a study, you have to compensate them for their time or they won't participate.
Yeah.
But you're not allowed to give them something that would incentivise them, so God
I
knows
see,
what
I
would
see.
incentivise a medical specialist, but yeah.
Mm.
Yeah, so but I mean a student, for example, you couldn't give them like $200 to participate in a study, that would incentivise them. You know, occasionally, I mean even doing something like having a raffle, like, you know, one of you will win an iPad or something, or even that, sometimes it's difficult to get through ethics.
I see.
So we'll have a large discussion about this whole
Yeah.
issue of recruitment and compensation and schemes to kind of
Inducements.
help reward participants for participation, because there's no denying that over the course of a study that's rather intensive, they're spending a fair bit of time answering questions and volunteering information, and we do want to honor their provision of that in some way. Our ethics board tends to be rather okay with us valuing their time decently well, but I will readily say that in some studies we've overestimated how big a burden it is on participants. Kurt met participants, remember from the e-cigarette and cigarette study, he said, I think you felt they were entirely unburdened, given the level of sort of the participant reward sort of fees that we.
I think the question that you said there's going to be a fuller conversation, and the diversity of burden is huge. I mean, it's anywhere from literally nothing because they're already using their phone to like every time you have a cigarette, take a photo of the people around you and ask this 6-point questionnaire. And that's not even a crazy thing to like. I mean, maybe not the photo of people around you because it's.
But no, you start and stop, right?
Like when are you starting the cigarette, and then when you're done the cigarette, press the button to say you're done the cigarette, and people might. I mean, that's pretty intensive. So there's a wide range of things that you can do, and how do you
Thanks for the money I could buy an extra pack of those.
Yeah.
Yeah, you don't want to, because we actually had a few people come in because we were doing e-cigarette stuff, and we asked, do you also smoke cigarettes? And we were interested in people that were dual users, and people would sort of say, well, I could start again. No. I mean, it was a joke. They didn't, but you have to be careful. If you're paying too much, then they're going to start again just so they can qualify.
Yeah.
That's not really something you
coerce.
coerce.
Big point,
Yeah, so
I start again so I can get some money to be part of this.
Yeah.
To be part of this study too.
Yeah.
The cigarette, smokers to put out their butt, let alone put out their cigarette butt, put it somewhere reasonable, because once they finish, that's it, they're done,
Yeah.
let alone do something else.
Can I- Can I ask, like, is there any case where that burden make them kind of quit? Like you don't want to smoke just because you think you want the burden? No, just
Well, I
out of
mean,
interest.
it's interesting because I didn't, in my head before coming here, I'd only sort of a small subset of the types of experiments you guys are considering. And one of the experiments you guys are considering, that I've heard multiple talk about, is you're actually doing an intervention study and you want to use the phone to reinforce their behavior within a certain intervention. So the idea of using a phone to examine their health-related behavior, to say if you are observing this behavior, then we're going to remunerate you for that. That might be a different question, because you actually are hoping to change their behavior through money.
Yeah.
And so that might be a different consideration than just paying to sort of have them participate in a data gathering kind of a situation. So that might be another dimension that we haven't considered yet.
So just in the interest of time, I do think I'll request if we could leave the discussion of this, participant recruitment and the financial side of it, in kind components, et cetera, till tomorrow. That'll be good. Okay, so the next study was this study involving contraceptive pill use and involvement. And does the team there want to describe it? Yeah, Mary.
So it's basically an RCT comparing two different pill regimes, contraceptive pill regimes, to see whether one is superior to the other with regard to symptoms in the hormone-free or the traditional hormone-free interval. So women get symptoms like PMS when they're not on the hormones for the week or whatever it is, depending on the regime. So we really want to use the Ethica as a daily diary type scenario, rather than having to do a daily diary, but we also want to track whether they're actually taking their pills properly. So we thought one thing we can do is take a photo of the pill packet, because it's really clearly labelled for the days, and you'd know whether they were missed pills or not if they take a regular photo. Something that we were just discussing around using level of activity is that it's actually it's a potential confounder in the study. So we thought by looking at level of activity, not only are you looking at it as a measure of quality of life, but you can also compare your two groups to see whether you've got your confounders accounted for. So that was one thing that we thought might actually be useful to put pedometry in there for that. But we want to keep it as simple as possible, mainly surveys, but a little bit of validation of that survey data through activity, and that looking at confounders I think could be useful.
Right. And as I recall, one of the distinctive features of this was some of these, a fair bit of the information collected will be proactively indicated by the participant, like, I'm taking my pill, and then it will ask, can you take a photo of the pill?
What we'd probably get them to do is we'll send them a notification once a day to say, have you taken your pill? And which pill is it you're taking? Are you taking an active pill or a sugar pill?
Yeah.
And then I think only once a week we get them to take a photo of the packet to show us that they have taken them all.
So they're making,
Just to monitor that they're actually complying with the study.
And these are these blister packs or some
Yeah,
other sort of
they're
packet?
like a blister pack, but there'll be either a month or 3 months worth of pills with the days of the week written on each pill.
So you could see with the photo, like
Easily,
some are
yes.
not been taken.
Unless they pop them out, so they don't take them when they realise they've forgotten something.
So these types of studies, like you're going to know if someone has like a severe headache, for example. Does that activate a duty of care to then do something about that?
It's a good
Or is
question.
that-
So that's what I was thinking, what if they've got really severe mood disorder?
Yeah, do you then
Then
required to advise
we'll
them
have to
do
have
something?
something in our ethics around
Yeah.
actually intervening or referring them out of the study if they've got really severe PMS type symptoms.
So are there some studies like this where you need real-time monitoring of it, of the
Yeah.
data, or?
So it's a great question. Like we have done it with, well, we have done studies where we have populations where we might pick up data of indication of risk. Example would be individuals and HIV infected individuals, some of whom are drug users, intravenous drug users. Patients with suicidal ideation in inpatient facilities, notably. And then looking at other cases with individuals with mental health disorders. There's a study coming together for people with severe depression in communities with high suicide rates. And there, one thing we've talked with the ethics board about, and which seems to be a strategy our ethics board is comfortable with, is making sure that they understand that this is not a real-time monitoring system, and that there's no guarantee that the data being looked at will be inspected, for them within any defined amount of time. And so essentially, we have to set very clearly in expectations when we talk with them that this is not an alert system, and put in the ethics consent form and in the protocol, make it very clear what this is and what it's not. And I think we might be able to help with a little bit of text along those lines, but it is a topic that maybe different ethics boards would have different requests on, but we haven't yet had a big problem with that, other than educating them about it. Okay, so here, I guess, in terms of data sources, automatically recorded ones, step counters, for example, would be useful. Time outside is, it's an interesting one, and we've done a lot of work on that, trying to understand if someone's indoors, outdoors. Mohammed talked about a lot of things of relevance, light levels, temperature. It turns out also GPS, because when you're outside, satellites are more visible than inside. The satellites, put aside the cell tower type assisted GPS, but satellites outside for GPS signals. And then Wi-Fi is less strong outside. It's further you go from a building, the lower the Wi-Fi. And what that means is trying to capture time outside may be a composite measure from several different indicators. And we'd want to think about how that could be reliably captured with a minimal of sensors to keep the study simpler.
But just to emphasize on the point that Mary made, if you want to keep that, I think there's a value in keeping the study the data sources also limited. Some of the data sources don't have any privacy concerns, and so the phone does not tag applications that use those data sources as potential privacy issues. So, for example, especially in Android, if you capture Wi-Fi networks in proximity, there is no issues. The app can operate just like before. So, or if you capture light level or temperature, so these can be easily added to the study and reliably, to some extent, determine whether people are indoor or outdoor without causing any issues. Adding the GPS then might cause people to perceive that, well, if I'm supposed to take if this is supposed to replace my daily diary, then why do you need my location? Which our response would be, well, we actually want to know whether you're inside or outside. But then, the perception of individuals of the study about the study changes, which affects it. And so
I think
thing
they
that
keep
you
it
mentioned
simple, and I think the pedometer is actually a benefit for them. They can actually, if they can get that data,
Yes.
some people would actually like that as an added bonus.
to see how far they have walked.
They
and
can
so
actually
on.
monitor
Yes.
what they're doing exercise-wise as just an added bonus from the study.
Or it can be an optional thing. We talked about the optional versus mandatory data sources. So we can just say this is, you optionally can provide your basically step count as well, and they can either opt in or opt out to that.
Right. Okay. So that's good. And of course, there's going to be a lot of reliance, as Mary emphasized, on the questionnaire. And we're going to see in just a little bit how you put those together. So that's good. So this next one also was from the same group on adherence to medication, right? 221. Is that Buna? Yeah. So Buna, do you want to describe that just a little bit?
Here we discussed about similar to that, we are also tracking the medication taking behavior, but unlike the pill study, here it's very difficult to take the photos because there will not be the complete booster package, and we are thinking about using some standard tools like the survey kind of thing to measure the adherence. So, and for tracking the physical activity, we could use the pedometer. And another one, we'd also like to see their follow-up pattern with the healthcare provider. So for that, either we could use the GPS or Bluetooth or beacons. Beacons would be the
It's interesting. Una was saying that they might go to the health centre with another family member though. They might not be there for themselves.
Mm-hmm.
So it would have to trigger a question.
We could answer questions to disambiguate. Yeah.
For the health center, that why or people will be asked.
Right. So when they go to the health center, I mean, one idea is to put a beacon there. Another would be to use GPS to identify when it's there. If it's one of many health centers, if they could go to any one of dozens, it might be hard to negotiate, that we'll stick a beacon in each one. Whereas with GPS, you might be able to say, okay, there are in this geofence around this health center, and then we'll ask a question, are you attending to that health center? And if so, is it for your own health or not? And use that as a means rather than relying on the Bluetooth beacon. Because the Bluetooth beacon would presumably require an OK by the facility, you know, for placement. An important thing that actually linked this in Mary's study, which I didn't emphasize, was this issue of you know, having questions that are structured involve skip patterns. So for example, in that one, when we asked, in Mary's, the 215, when we asked did they take their medications today, for this one here, you know, if they do not indicate taking medication, we might ask them a question. In both cases, what got in the way of your taking your medication, right? Was it a problem? And Mary had noted that for the contraception ones, we might provide some advisory information, you know, depending on if they were going to take a sort of a sugar pill or a so I guess it's kind of a placebo or versus a hormonal pill. We might provide them some guidance. If they forgot a hormone pill, we might say, okay, you know, you should continue to take your pills through what would otherwise be a hormone-free period, right? Because of risk of pregnancies, of unintended pregnancy. So, so here, once again, there might be elicitation with a questionnaire of what might the barriers have been, and there might be an open-ended option where they can record an answer or type an answer in text if it's not one of these. So you can understand something about that. And the physical activity and dietary habits, were those to understand the relationship to the pill-taking behavior?
Yeah, the outcome would be the one would be the adherence and the blood pressure control. So there we can see whether the adherence is active on the blood pressure control or the other things.
I see. Okay. So these are, I forgot, these are pharmaceuticals to help regulate blood pressure?
Blood pressure medicine.
Yeah. Okay, I see. Yeah. Okay, great. Yes, Roberto.
Is it reliable, that calorie consumption data that is available from some applications that they see?
So I did a fairly close review of the literature on this for accelerometer-based methods for estimating calorie consumption. And the distinct impression I got from there, this is a number of, you know, this probably would have been maybe 2013, 2012. So it was some years ago. But the consensus seemed to be that using accelerometry alone, even, you know, from well-defined actigraph accelerometers, to directly go to caloric consumption was problematic in the sense that it had big error bars. And however, if you combined it with heart rate, you could actually do really quite well in estimating it. And this gets to my point earlier about heart rate variability. My comments about heart rate variability and stress detection are not that I think it's not important. I think it's extremely important. I actually think it's very high potential. My point was, you want to be cautious about just investing in faith in it on its own basis. Often what you need to get reliable insight or more reliable insight is to combine a couple sensors. So you at least you want to know something about posture and heart rate variability as measured by IBI intervals, by intrabeat intervals. Then you're getting much more reliable understanding of heart rate variability in a way that's meaningful for stress. So similarly, for caloric consumption, you really want heart rate together with accelerometry to do a good job with accelerometers, is my understanding. I stand corrected. I'm not an exercise physiologist. Maybe someone else in the room has updated knowledge of literature, but I think there's a lot of apps out there that promise some understanding of caloric consumption, and I'm not sure how reliable that is. I'm fairly skeptical. I've also done some evaluations of it against more reliable indicators of step counts and found some pretty good discrepancies. So I don't know. I think again, caveat emptor, evaluate it critically, on your own before investing faith in it. Yeah. Other questions? Other suggestions for this? Mohammed, do you have any?
No, nothing.
Suggestions? Yeah. Okay, so this one. So there's a couple here. Number 5 here. Is this a different one? This
And that's part of the same.
part of the same. Okay. So does someone want to take the lead in sort of characterizing this ED focused thoughts?
Oh yeah, okay, fine. So what we're looking at is we're looking at trying to learn something about patient flow through emergency departments, and this is really a bit of a brain dump rather than but essentially we're thinking that what we need is mostly survey information and position information, but it would also be useful if we had some information that could tell us when the patients interacted with medical staff, so perhaps some contact information. So that blue
Blue
thing
2P.
sounded interesting, and that what I was wondering is whether you could actually connect that to the clinician's name tag, for example, or their pass that they wear around their neck, and then have the patient with the phone. Because the difficulty is that the clinicians won't have time to interact with the phone, whereas the patients will. So, yeah.
But do clinicians carry the phone with them, or?
Clinicians would carry a phone with them.
They would.
They would.
Would. Well, Marcus, if they're
They all have phones.
Yeah. So,
Yeah.
So do you think it would be a problem to have the
you said it
beacon?
doesn't work on these.
Oh well, but I'm saying, for example, would it be possible setup for patients to carry the badge, and for clinicians to have the phone with them. They don't necessarily have to interact with the phone, but as long as they have the phone with them and the app installed on their phone,
It's
it gets
recording data.
captured. The reason I suggest that is that asking because visits to ED is not something scheduled, right?
Yes, yeah.
So people who come there very likely don't have the app installed.
Right, and that's my question for when we talk about recruitment.
Yes,
Yeah.
exactly.
Okay.
So then that's going to be a barrier for data collection. Versus it's very easy to tell them that, well, as soon as they come to the emergency department, you can tell them that keep this badge with you, and then the clinicians will have the app installed on the phone, and it captures the data that way. What do you think is the barrier
that
there?
would capture the connect data, but it wouldn't allow us to survey the patients on their
Oh,
experience
I
as
see.
they move through. So because probably the connect data would only be used to trigger a
The
question.
questionnaire.
Yeah.
Yeah.
So you've just seen a medical practitioner, you've just seen a nurse. What was your experience with that? What some questions around that?
Okay, so one thing we're exploring in another clinical context, actually associated with dementia, is providing the visitors with like a tablet when they come in.
Oh yeah. Yeah.
That would then be used to elicit some information from them. And while they are in the facility, whilst they're interacting, you might have questions triggered on that based on their encounter of a physician, and then they would leave it at the front desk or so on. Now, you need to make sure they're not serving as fomites or something. You want to rub them down with baby wipes or something. But the point is, it obviate the need for them to install the app. Now, if this was a primary care clinic, as we're working with in a different context with nurse practitioners, asking a regular patient there to install the app that's a quality improvement app is not outlandish at all. But for an ED, it seems too much.
Yeah, so the reason I mentioned that is that one thing that you need to consider is that installing an app from people's perspective is a commitment, right? So like every time even you want to install an app on your phone, you think about it before, right? It's different than opening a web page. So that's something very important to keep in mind.
Mm-hmm.
And if a person comes to an ED for one visit and they don't expect to come again, they might not want to install an app, and even if they might accept doing that, asking nurses to remind people as part of the procedure to do so is a change in the nurse's
we wouldn't
procedure.
We wouldn't be able to do that.
So basically, somehow you have to inform visitors to install the app, right? So that's why I think it's a bit of a. So if you want to help with that situation, one alternative that we are working on right now is to have the same scenario. Basically, people have the badges and patients and clinicians to have the app installed, and then patients receive the questionnaire in the form of a web-based survey as a link to their phone, like on their phone, that they can open it as a web page, answer it, and then submit it when they're done.
Without an app.
Without the app, yes.
Oh, okay.
So that's also something that we are working on it.
Even this morning or yesterday, you walked us through installing that app. You also walked us through how to register for the study, etc.
Yeah.
So presumably, if you're trying to do this in a waiting room, you would actually need labour there to help people do the installation.
Yes.
Under, they might be nauseous or worried about their child. So I agree with you. It would be quite awkward in that situation to manage smoothly.
Yeah. So as Nate mentioned, if these are patients to the primary care facility, so it's not out of place to ask them to have the app installed, because they are going to be in the hospital for some time, and it makes sense to them as well to have the app installed, to have more communication
And
with
even
people.
if you invest the help to do it, it's done once.
And they have it. But for ED is a slightly different scenario, and that's why I think the flow of patients having the badge, clinicians having the app installed, and then patients receiving the surveys through a link when they maybe a few hours after the last interaction with the clinicians is detected, is one scenario. But this is, again, the assumption here is that we want to only ask one survey from them. If there is more interaction that you have in mind, then there might be a different scenario that can be.
Yeah, I actually had quite a bit of, because what often happens with these patients that we're looking at, which are these triage 3, 4, 5, is they can actually sit in the waiting room for like 6, 8, 10 hours.
Yes.
And the idea was to try and see how they feel about their visit or their interaction as time progresses, and whether they have a good understanding of what's meant to be happening to them and where they are in the system, and how that understanding changes as they move through the system, and then their response at the end of the process. The other thing with it too is if we could get them with an app on their phone, we've got a 28-day readmission flag as well, so you could actually see if they came back within the 28 days, what occasioned that. So that's sort of what I'm thinking. But I do get since we first started yesterday, I'm like, how do we recruit them? Because that's one of the big issues.
Yes, exactly.
In our context, we have something like 40% of the ED visits are from, well, they used to be called frequent flyers, and now they're called friendly faces. But
It's suggested that we do that with people that are frequent visitors, because they might be more inclined to actually install the app.
That might not be the group you want to study here. So
Yeah.
it's probably
Because if they to keep coming back, whatever is happening in their life keeps on coming back.
Yes, exactly.
I mean, maybe it's possible to, and again, I guess recruitment's outside the scope for now, but maybe it's possible to recruit people formally who are frequent users, but have flyers around for people who are just tech savvy and are sitting in the waiting room for 8 or 10 hours that might want to download the thing. I mean, at the moment, I'm not even sure what the Wi-Fi capability is in some of these waiting rooms, and whether it's possible for people to install on in the waiting room.
We've actually given out devices to use, which would solve a lot of the app problems.
Yeah.
Have you had problems with recovery? People see that as their incentive.
So yeah, I mean, I was going through this in my mind as we were talking here, and so giving tablets out, you know, giving tablets as they're waiting and maybe waiting there for 8 hours could be a double-edged sword. I mean, it could actually be viewed as kind of a nice gesture in the sense that, oh, okay, you're letting me, yeah, exactly, you're letting me, I observed that at Qantas. So there's these little tablets you give out, and you know, that was news to me, and you know, I could imagine for people sitting in the waiting room, it actually might not be bad. In terms of walking out with them, I mean,
And what you're spreading.
and what, yeah, well, that's what I was mentioning, the fomites and needing to wipe it down with the baby
But
wipes.
if
Someone's gotta do
you
that.
leave the premises, they don't work.
Sorry?
They die.
Yeah.
They have a suicide pattern. They
From
kill,
my-
so there's no point stealing.
From my view with this
Programs
study
to
though, it's a
actually
moot point, I don't have research funds to provide
Yeah.
such tablets.
Right, but the other thing is, they should know that those tablets are tracked wherever they go, right?
Yeah, absolutely.
So if they walk out,
Yeah, we know where
we know exactly where they are.
We need the things that go beep, beep, beep.
Yeah,
as you go out the
and,
door.
you know, in terms of recovery, we have had diversion problems at a very low level. You know, I'd say it's maybe on the 1% level, maybe 0.5%. It's probably been at the level of damage to devices. But we have observed where, like, there's one phone going around Saskatoon on Circle Drive for a while. It was one of our phones, you know, and one of the patients from the psychiatric unit walked out with it and continued to use it, and the app's on there, and you know, we know where it is every night and so on, but we haven't tried to go retrieve it. They didn't bother to uninstall it. I don't think they're answering the questions anymore, but I should probably check.
That's might need to write to your ethics committee.
Yeah, yeah, moving right along. Yeah, we're just perplexed about what we gotta do about it. I'm not quite sure, short of getting the police involved, I'm not sure, you know, I'm not gonna be the repo man, you know, and.
Can't you send a message?
Sorry?
$50 if you bring it back.
Well,
Send a message with
yeah,
the text.
yeah, potentially we could do that. So, you know, I think this needs to be thought through. It sounds to me basically like there's a couple different ways between these small, cheap Bluetooth beacons and asking people to consider installing the apps, you know, that you could get some significant insights here, but that would really be something that needs to be thought through. And then I think ideally there'd be this option of having device, you know, that could be used, and it's used on the condition they answer questions with it. But I think Mohammed's idea about this online survey is actually an interesting one too, and it's a point of some.
What's the cheapest Android phone on the market? Can you?
It's around $70 US.
So it'll probably keep falling.
Yeah. So there's a lot of questions here that would be informed by these questionnaires that could come up, and then it's asking every 60 minutes, 30 minutes, so that might be ecological momentary assessments, probing them on their concerns about their perception of what's going on, and then upon departure. And these, you also mention here patient-reported outcome measures.
Yeah.
Would that be after they circulate back in the community?
Yes.
So they're having a phone or a web survey mechanism. One of those is critical to be able to deliver those patient-reported outcome, collect those patient-reported outcome measures.
That's an important part of what we learn, I think.
Yeah, and continued attitudinal outcomes as well as kind of health outcomes?
Potentially, yeah. I mean, it's early days.
Yeah.
But, yeah.
So these might include considerations of representation?
Yeah.
Yeah. So returning there. Yeah, and admission to ward time and ED boarding time, yeah. That's good. So there's, in addition to these, because a lot of these seem focused on patients. But then there's also the interest in the contact with the care professionals, right? And the questions are not being asked to the care professionals, they're being asked based on the patient's encounters with them. You might ask questions of the patient.
Yeah, we didn't want to ask questions of the care professionals because they don't have time.
Overloaded.
Yeah,
Yeah.
they're already doing it.
Yeah. But you're also not interested in mining information about like who coordinated with who about this patient as an explanatory variable for outcomes. Yes.
Oh, I'd love to, but
Yeah.
the outside scope, but
Yeah.
yeah.
Okay. Good. Other comments or questions about this one? I would note that, and this is just purely parenthetical, but it will link into some comments I'll make tomorrow or the next day. All of the studies thus far have been what I would view as kind of EMA plus or survey plus studies, in the sense that there is, maybe that's not quite true, but there's sensor data being collected, but it's often used to kind of explain or give context to the questionnaires. Maybe that's not quite true. Like recording screen time here, aspects of dietary habits here, and maybe something about activity levels. There you might be collecting more fulsome sort of information about a student that could be used to understand something about like who teachers are spending time with or outcomes there. You know, here I think there's pedometry and so on, which again maybe provides some explanatory factors involving measures that would explain adverse effects of medication regimen that wouldn't otherwise be measured. Here, for adherence to medication, there's physical activity and dietary habit being collected as, so I guess these are kind of explanatory factors. So I actually misspoke. It's not so much just that they're labeling the context for things, but here you would be using, I think, potentially the sensed data about where they are, who they're with, to trigger questionnaires under certain context.
Nate, one
Yeah.
question. Can we use, for example, use the mobile to record ask the question and record that and transcribe it using as like a part of a mixed method study?
Well, you can use the phone to record. In fact, Mohammed will show there's a questionnaire so a questionnaire type of item that you can add to a questionnaire, and that before the day is up, you will add it. It's an audio question, okay, and it occurs in its own form as audio response, or audio or text, given their choice. So they can say, I want to give an audio response, or I want to give a text response. The person can choose. Think about an older person who might have trouble typing, they'll prefer audio. A young person like Kurt, in the fullness of his youth, might prefer to type.
You're giving him a complex.
Well, he's a complex scientist.
So Kurt, Kurt might prefer to type instead of audio. And the point is, we can collect that information very easily with audio. Turning it into text is challenging because, as you've noticed, perhaps with every single word that I have spoken, there are a diversity of accents in the world, right? And some of them are hard to understand even sometimes, and it's even harder for a computer to translate it into text. So the current state of transcription technology is not reliable enough to just magically render it into text in a general form. And the reason is text recognition, or recognition of the text from a spoken word is quite easier to do with a limited vocabulary. So if you say yes or no, or you select option 1, 2, 3, 4, 5, it's really quite good at recognizing. But once you start getting to unlimited vocabularies or very large vocabularies, it's very hard to get the level of precision that will be required by a research team. And in principle, something can be done on first pass so that you have something crude to start with, but right now, for I think good reasons, Ethica doesn't support transcription because it is too reliable to really count on. And there's other tools out there that will do transcription that you could use and then have someone correct the transcription. Yeah.
Does it support the built-in text or voice recognition on iOS and Android?
I don't think there's any.
Yes, you can do that because that's by default. Yes, but the reason that Google and Apple and now Google a lot better than Apple provide voice recognition. Like you remember when Siri was released, Siri was pretty good, but then now Apple's Google Now works a lot better. The reason is that these are relying on the amount of data that they collect to train their algorithms. Because it's not that Apple's algorithm is worse or anything, it's just they have less data to train their algorithms on. And everything that you say, it's not on your phone only. It's actually sent to their servers, it's processed there, and the result is sent back to you. So if your phone is offline, you can't use any of those services. And the reason that they are so reliable is that they have voice from billions and billions of people who use that, and they have their algorithm is so well trained. If you actually want to do it, if you want to write that algorithm yourself and just try it out, even if you have a copy of their algorithm, it's nowhere close to what they can provide.
If Ethica was to capture some metadata and brought that together with voice, so for example, I told you that I had the worst experience in your easily possible interview, and then afterwards automatically said, was this a negative or a positive story? What were you complaining about? Could you handle that in the system? I think it's more positive.
So
I think there is a field of research on that as well. It's called sentiment analysis of text.
Yeah.
Which basically, based on the text, they try to guess whether it's positive or negative. It's not something that we have integrated that, and it's actually also sophisticated because.
No, I didn't mean automatic sentiment. I meant sentiment as the person who made the voice message ticks a couple of boxes.
Oh yeah, you could have.
Yeah, you can
have the sentiment themselves.
Yeah, but
which lets you classify it, so you're not listening to everything.
Yeah, of course. That can be done easily, but if like analyzing the text that they have typed and extracting the sentiment of the text is actually slightly more sophisticated.
Yes, absolutely.
So is there a time limit on the audio question, what it will take?
No, they can talk as much as needed. Yeah.
So, and you just get to listen to it, it doesn't get.
Well, the longer
You
it,
can transcribe it if you wanted to.
So
You can't just listen.
tell you what, we'll add an audio question to one of these surveys today, and you can see, experiment what it's like. Basically, you record it, and then when you go to the website as a researcher to look at the data collected, there'll be a little thing where you can play it, and it will play for you what was recorded, and you can then copy it down, transcribe it, what have you. Yeah. And that's different from ambient audio where it just periodically records, samples of sound in the course of a day, which I know Mohammed has worked on for a study with schizophrenics, I think. Sort of just recording at times during the day what's in their environment, which has extra ethics sort of concerns because other people's voice could be recorded. Yeah.
I just know when I had a 10-second voicemail message, there were people that couldn't cope with that. As in they couldn't get the information they needed in that.
Oh,
My
yeah.
mother-in-law, so when you're saying older people prefer an audio.
Yeah, but it can be open-ended, so, yeah. Okay, so the final one was dementia carers. And does someone wanna take the lead with that?
Sure. So this is sort of an idea to look at the sort of health and quality of life of caregivers for people with dementia, and possibly, hopefully, we'll understand their demand or their need for support. So we try to collect sort of a range of indicators of health, quality of life, or demand need, and I'm trying to find it here because I don't know where it is anymore. Okay, here you go. So one of the first things that we want to look at is the self-reported health. So we're going to do a survey on, of various kind of health instrument, but we're also interested in looking at the hours of sleep at night, the change in stress level, the number of hours spending outdoor per day, the number of hours spending on care duty, absence of illness, fatigue, and nutrition. So out of all of these, so we're thinking apart from self-survey, we will look at wearable, light sensor for sleeping or indoor, outdoor. Definitely the beacon is a really good idea because we're thinking that if we have a beacons in the house of the person with dementia, the carer come in or come out, we can measure the length of time they spend inside or outside, and also we can actually from that actually prompt questionnaires. If you inside for too long, how do you feel? Asking why don't you go out, or if they out for some particular reason, we can understand if they out for respite or they out for work. Sort of along that line. So the other aspect of we look up, and then we're also interested in probably for absence of illness, looking at taking photos of medication or some sort of measure of activity, physical activity. For nutrition, taking photos of meals, alcohol intake, and asking questions as well. So about quality of life, so this is a very, very popular topic, measuring quality of life of people with dementia and their carer. So we probably will have a survey instrument where we try to pop up every day, asking them how do you feel today about your quality of life. And we might also use an EQ5D to measure like every week or every month on that. But we're also interested in using all of the sensor to measure, to get a proxy measure of their quality of life. So in EQ5D, there's 5 mentions about mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. So we think for mobility and self-care, we can use physical activity sensor. Maybe, beacons somehow, I don't know. Maybe some sort of GPS location, contact patterns for usual activities. Pain and discomfort may be wearable, photo of medications, some report on alternative therapies that they take, meditation, yoga, communication behavior maybe, and alcohol intake. And anxiety, depression, quite similar, and pretty much it. Actually, we're also interested in work participation as well, which I guess it's more like our work per day and something about job satisfaction. But how to use sensor for that, I'm not sure.
So work participation, you mean like their work hours?
Yes, that's right.
As a sort of explanatory factor and
that's
sort
right.
of understanding?
So carer can be full-time carer or part-time carer. And I mean, some carer actually don't have a full-time job anymore, but they might still volunteer sometimes. So those are quite important aspects that we want to look at as well.
So, it's one thing that, one thing that we did for one sample study was to probe sort of, essentially get people to mark where they worked and where they lived. Mohammed will remember this survey. I filled it out many, many times. Why are you at this space? But it could be done in a more proactive way by someone to sort of initially mark, okay, this is where I work, this is where I am at home. And then GPS could be used, on Android Wi-Fi alternatively, but probably GPS would be both platforms. you could think about a beacon, but the issue with beacon is not all workplaces will be comfortable with them marking. Although I guess you could put one on, if you worked, and this gets into socioeconomic assumptions and so on, if they had a desk at their workplace, you know, you could potentially leave it there, but think about someone who works construction or you know, someone who's a farmer or something. It might not be that they would need a place that they can go. It might be more GPS delineated. So that might be something that could be captured. By contrast, when it comes to caregiver contact with the cared for individual, there a Bluetooth beacon is probably fine because they could place one there. It would track how frequently they go there and how long they stay, right? We are, just as a point of clarification, are you looking for change over time in these things, or you're just looking, you are?
Yeah, absolutely,
Okay.
that's what, I think the purpose of this study is we think that caregivers really need support when they care for people with dementia. But the problem is a lot of the time when they seek help, it's already too late, they already have a breakdown or crisis, and because of that, the people with dementia might be admitted to nursing home premature. So the purpose of this sort of study as a pilot and then in the future is try to understand if we can predict beforehand the crisis and, you know, somehow put an intervention, maybe just a phone call or some information to help them,
So it would be
you know,
based
jump
on
through the hood.
the length of time the person's had dementia.
Absolutely, yeah. So, yeah, so the pre-survey will include, you know, the moderate, severe, or, you know, mild level of dementia, what type of dementia they have, and how long the carer have been caring for this person as well. And in the form of if it's a full-time caring or share care, and, you know, a certain type of question that we tend to administer for the dementia dads as well.
Mm.
And then within that, we try to track over time to understand the determinants of the health and the quality of life, and when maybe we can predict breakdown. And, you know, yeah.
If not everybody would be doing this study, just have a check-in call or whatever, after so many length of time.
Yes.
That you're caring, so.
Yeah.
Mm.
Does
So-
Ithaca actually have any alerting capability? Because again, I'm thinking you're almost going to bump up against duty of care issues again.
Yeah.
If someone's obviously not coping and you don't look for 3 months.
Yeah, well, I mean, I think when you raise that point, I think it's really relevant to us, and my answer is, I have no idea. I guess when we get there, we will have to get consumer be involved, and they will have the capacity to advise what they think is appropriate. So those kind of projects, we do have pretty much consumer representative fully involved, and I guess
I mean, you can do what Nate said, which is say we won't react to the information, so if you need help, you can do it another way. Or you could have some sort of alerting capability built into the platform.
Yeah.
Or you could regularly pull your data down and have a look at it. Those are your 3 choices, I guess.
Well, there's a few things you can do. You could have something called an information service, just text.
Yep.
And you can have phone numbers and URLs of websites
So help.
in there.
Yeah.
And that could
pop
be,
up when someone.
and that could be triggered if you, say you do a mental health screening questionnaire and, you know, and your score on that is beyond a certain level, or your answers to certain
Yeah.
questions,
Yeah.
you know, I think you're gonna harm yourself,
Auto
or something like that,
Yeah.
that gets triggered. You can also have user triggered surveys which you can use in a somewhat workaroundy way, just have that information survey sitting there, so that whenever you have a Ethica or something called resources, if you're feeling, you know, particularly down or something, you can just open that up and refer to it whenever. Or you could go for the more high-tech intervention, just
Yeah.
triggered by.
This issue of, it's a good question, Keith, but I think for a number of reasons, we do want to distinguish very separately, you know, distinguish between, delineate what the types of things Ethica attempt for in an alert system, because an alert system depends on real-time connectivity that cannot be ensured with Ethica in terms of, you know, there could be prolonged periods where a person's in a rural area without good connectivity, where a person goes without access to data plan because of financial circumstances or turmoil in their life, technical issues, and you know, the implications liability-wise and ethically incumbent upon ensuring an alert system. It goes well beyond what you know we would conceive of as being desirable, and actually it would. I think it's a fundamentally different type of service that's talked about there.
Yeah, I agree.
And I think having a consent forms that make that clear to the participant, and yes, maybe allowing them to have their data loaded, so that they could see their own data, et cetera, in some circumstances and reflect on it, or see it in a way that's meaningful to them. You know, those are more acceptable solutions than, you know, considering something that would make promises of alerting.
Yeah.
In real time. Yeah.
Yeah, some ethics committees are very big, dance along that line before,
Yeah.
even just measuring height and weight sometimes. You get asked that you should be doing something about it, and you're going, "Then what other avenues for that?"
Yeah.
And that's not the intent nor the capacity, it's a study,
Yeah, and capacity being a big issue, you know, taking that on as a responsibility is weighty. Yeah.
I wonder in terms of the design whether we should focus on who is the target population. In that case, we are concerned about the carer, or how we monitor the carer needs for relief and or stress level, or level of worrying about the person, where the person is gone missing, or things like that, how to track that person, things like that.
Yeah, I guess I totally agree with you, because the purpose of looking after the carer is also me looking after the person with dementia. When I was thinking about it, maybe the way to address is probably some sort of survey question that, you know, like the trigger or the user trigger, that they can actually do it when the person is missing or they work. But yeah.
Or maybe recruiting the both, one is the carer and the other one is the person with dementia.
Yeah,
The
so
dyad.
the diets is usually, that means we will involve the diets anyway. But I guess that's when we present this, is more like at the moment that's what we think. And then in the future, our purpose is really actually extending to make this more like a peg, wearable, or phone or something, where the carer can actually see the movement of the person with dementia.
Mm-hmm.
And because from that we can understand the interaction between them, which for me personally very important, because I can use that for modeling. So yeah, I mean that's down the track, and you know that's absolutely
Yeah.
something we would be interested in. But for the time being, we just want to have a size, you know, bite-sized size and doable.
And it bears noting that for studies where you do have populations that require guardians,
Yeah.
like people with dementia, like children, it may be that the guardian logs in, has that login access as a participant, you know, to the site, and could launch something about their cared for one. But this issue has come up in other discussions Mohammed have had some time back now on with people with people whose children in adolescence or adulthood with autism.
Yeah.
And you know, the parents being very concerned about the transition to adulthood in their children, wanting to make sure they're okay, wanting to make sure they're not homebound and so on. And once again, that's something where the caregiver might log in to see some information about their loved one, even as that participant, because they're doing so in a custodial capacity. Okay.
So just one thing I wanted to mention about this. This is one of the cases that I believe the more you rely on sensor data, even if the data that you get from it is not as accurate as surveys, the better. compared to using surveys, because the population that you're dealing with are a population that are very much overwhelmed. And the last thing is they need is to answer a couple of, even one survey a day, right? So this is so that's and in this context is even probably is very justified to ask them that we would like to monitor different behavioral aspects of you, including, for example, your communication pattern, your location, and so on. Which, because they are already motivated to provide, like to basically participate in the study, probably they don't mind sharing those information. So this is, I think, one of the cases that if I think it makes total sense to, where possible, reduce the number of surveys and increase the number of data that you can passively collect. And well, we haven't done any study. None of the studies that we have been involved included these populations, but I've read about it, and I've talked to people who were doing research in this area, and they all were emphasizing that it's very hard to ask them or expect from them to be compliant with filling the surveys.
Yeah.
Right?
Yeah.
So that's also one thing to consider.
It's a good point, and this issue of phone, like of communicational behavior, if there were an aspect, because you're particularly interested in this bond between caregiver and the person being cared for, and how that has changed over time and so on. And so looking a little bit at calling behavior, for example, might provide one aspect to complement physical visits.
Yeah.
You know,
That's true.
and
it probably worked for mine to moderate dementia.
Yeah.
I think when they're at the stage of moderate,
Yes.
a lot of them can't actually communicate in language very well.
I see.
Yeah, so they can be like, they want to live on their own, but they really don't, they can't actually easily
patience.
understand, you know, other things or communicate. But yeah.
But
I
that
think
could be
you're
an
right. It's a
important
contact, yeah,
factor in
that's right.
explaining, for example, sudden changes in mobility patterns. Because if I can't speak with my mother anymore, you know, I can't reach her via phone, that may change my frequency of visiting her, you know, increase it so I see her more in person despite the extra time or something. So in terms of understanding what's going on, the narrative, as it were, that may be important as a potential judgment. Okay, people, I want to thank you so much. I know this is this required a fair bit of time. I think it was probably an exercise well undertaken, because it does link in with what some of these data sources are, and it puts us in a great stead for what we'll do after the break, which is get you going building some surveys, okay? You'll see the survey building interface. It's a graphical interface, and you can build up a few of your questionnaires as part of that before you head home for the day. So thank you very much, and tea is served.